I'm Dave Woldridge, and I have the pleasure of introducing our speaker today. I wanted to give a little background about the Goodson Lectureship. So the Goodson Lectureship was established in the memory of Dr. William Goodson, Jr., a longtime internist in Kansas City. He was born in 1909, the son of William Goodson, Sr., a family physician who practiced in Liberty, Missouri. William Jr. was a Phi Beta Kappa graduate of the University of Missouri, and in 1934, graduate of Harvard Medical School. After service as an intern in Hartford, Connecticut, he returned to Liberty to practice with his father for a year before traveling to the Mayo Clinic for a 3-year fellowship in internal medicine. He then returned to Kansas City, where he practiced in general internal medicine rheumatology from 1940 until his death in 1985. He practiced at Trinity Lutheran Hospital during his entire career, and among his other affiliations, he was a UMKC Year 1 docent from 1980 to 1982. For Dr. Goodson, medicine was his true avocation as well as his vocation. Like his father, who practiced until age 82, Dr. Goodson saw no reason to quit, and he saw 10 patients in his office the day before he died. By all accounts, Dr. Goodson was the embodiment of the dedicated master clinician, and at the time of his death, his family, patients, colleagues, and friends established this educational program to perpetuate his spirit of inquiry, discovery, and commitment to patient care. So since 1986, the Goodson Lectureship has brought some of the country's finest internists to Kansas City. In my 35-plus years at UMKC, the Goodson Lectures have been among the most memorable and impactful that I have encountered or my peers. In addition to the lectures each year, we've also been honored to be joined by members of the Goodson family, including Dr. Goodson's 4 children, Liz, Grace, Bill, and John, and we are in the presence of generations 3 and 4 of William Goodson physicians. This year, John Goodson, a prominent primary care internist at the MGH, who helped spearhead this lectureship and was himself a Goodson lecturer in 2016, is joining us remotely from his home in Boston. His career as a model academic internist was recently highlighted in his YouTube, Dr. Goodson Tells His Story, the link to which I will share in the chat. Carrying on the legacy of outstanding internists to visit UMKC and St. Luke's as Goodson lecturers this year, we are thrilled to be joined by Dr. Heidi Miller. Dr. Miller trained at Yale University and Harvard Medical School and completed a residency in internal medicine primary care at Harvard's Brigham and Women's Hospital. She's the Chief Medical Officer of the Missouri Department of Health and Senior Services. She provides clinical and strategic input to all divisions of DHSS while fortifying public health policies and programming across the state. She prioritizes unifying and optimizing the integration of public health, population health, and healthcare delivery efforts. Focus areas include workforce development, physician pipeline development, GME, maternal health, substance use, chronic disease, access to care, state standing orders, public education, and emerging health issues. She previously served as the medical director of the St. Louis Regional Health Commission and the St. Louis Integrated Health Network, and was the citizen filer of the Missouri Ballot Initiative for Medicaid expansion, which passed in 2020. Importantly, Dr. Miller continues to serve as a primary care internist at Family Care Health Centers, FQHC in St. Louis. Hers has been a remarkable career as a clinician and leader committed to improving the public health of all Missourians. Please join me in welcoming Dr. Heidi Miller to UMKC. Thanks, Dr. Miller.
Thank you so much for such a nice introduction, and thank you for hosting me, Dr. Woldridge and Dr. Lathan, and the Goodson family, and the, can you hear me?
Yes, we can hear you.
Okay. Thank you for, to the UMKC leadership for having me. I'm very, very grateful for this opportunity. So I would like this to be interactive. I don't want to just talk at you for 60 minutes. So I would ask, please, that you not reserve questions to the end, but please just interject or raise your hand, whatever you're most comfortable with any questions, comments, or reflections. What we need to do as internists, as physicians, and as stewards of public health in the state of Missouri, and for some of us, Kansas, I need you. We have to do this together. And so I really welcome your input. The focus of my talk will be on Missouri, but raise your hand if your work is focused in Kansas City, or Kansas, sorry. Okay, good. I wanted this to be as applicable as possible. I know that some of you, even if you are in Kansas, this will be applicable, and it will give you the questions to ask in order to change policy in Kansas as well. I have no financial disclosures. So why public health? I'm going to start this with, why did I choose internal medicine and primary care? I can't take care of one part of the body without worrying about the other part of the body. I can't focus on one organ system without thinking about how it operates within the entire holistic being. And when I was in residency, and thank goodness we're all different, some of my colleagues would have such delight in having their finger on the pulse of the very sickest patients. And I enjoyed intellectually the skills of that and learning how to balance so many organ system failures simultaneously. But I cringed at the fact that 80% of what I saw on the internal medicine wards was totally preventable. So that drew me to primary care. And then after doing primary care for 20 years, I realized that my patients are coming to me so sick from their environment, for their social and structural determinants of health, from their intergenerational effects of racism and housing discrimination. And I realized that I needed to move even further upstream, whether it's their lead exposure or the black mold in their rented apartment or the lack of food or the lack of maternal-child health dynamics. It made me want to move further upstream. And that is what drew me to this public health position 2 years ago. Now, the other question that I've been asking myself for 2 years in this position is, what is public health? Because as I have learned how public health is implemented across the state, there are government public health agencies that are doing what you would think like tabulating tuberculosis rates, but they're also doing direct clinical care. They're doing STD testing, and they may have a nurse practitioner who helps do lead testing for kids and maybe some preventative services for kids. And then when I learn about that in this public health structure, the primary care doctor in me is like, primary care doesn't have enough money, public health doesn't have enough money. Why are we hiring a nurse practitioner to do STD testing on Thursday from 9 to 12 when you really need that every day of the week? And I have never in my career tested for STDs without also asking about contraception and without ultimately touching on some social and behavioral health issues to explain why this 17-year-old is smart and knows that a condom would protect her, but didn't because she felt so domineered by her partner. So let's not fragment, let's not silo within public health. And then, when you think from the healthcare delivery side, I remember being quite surprised, as many of you during COVID, like, where's our public health structure? Because it was me as a primary care doctor on a blacktop for 4 hours in a spacesuit and an N95 mask doing testing through the driver's side window for COVID. And then it was our hospitals that were disseminating the COVID vaccines. So our healthcare system is doing public health. So what is public health? And who is doing it? And I would argue today that it is you, it is all of you. And even those of you who want to specialize and become a vascular surgeon, when you tell the patient to quit smoking, after I've told the patient 20 times to quit smoking, but they can't get their surgery until they quit smoking because the super specialist told them to quit smoking, they're going to quit smoking, and that has an ultimate ripple beneficial effect on public health. Here's the agenda today. I want to share with you briefly the health status of Missouri. And then I want to explain the public health infrastructure as I see it. I've been in this position for 2 years. I think it took me the first year to understand how it works, who's doing what, and here's what's most important. Who is making the decisions about what we do behind the exam room door, and the decisions that most impact our patients. Then I want to talk about public health funding. And again, I'm going to keep thinking of public health in a broad way. Funding, follow the money. Whether you are trying to improve systems within your own hospital, your own health center, your own private practice, or within a governmental jurisdiction, everything comes down to the money. And the most fascinating parts of my job has been budget hearing meetings. When our legislators are evaluating our budget and we need to explain why we are spending resources on certain programs. Then you cannot talk about public health or healthcare delivery without health policy. Health policy is infused in everything that we do, whether or not we realize it. And I mentioned this to a group last night that early in my career when I would teach medical students, I loved teaching medicine. I loved teaching the physical exam, the differential diagnosis, how to do a knee exam, how to meticulously balance multiple chronic illnesses. But now I can't take care of patients without seeing policy in everything we do. So now when I teach, I'll say I'll explain why this patient went to jail because he tried to kill himself, and that's illegal in the state of Missouri, but he couldn't afford his Prozac because he didn't have health insurance, and that was before Medicaid expansion, and that's why we're here today, and he's on disability. Like every single patient, every single thing we see, things that work well are a function of good policy. Things that are stupid and frustrating that you encounter every day on the wards, in the clinic, those are a function of policy. Policies can be changed, and nothing is more seductive to me than a fixable problem. Then we're going to talk about next steps. And throughout, I want you to ask questions. I want you to make connections, see this synergy between healthcare delivery, healthcare education, health, public health, and health policy. I tried to imagine a perfect diagram of this for you today, and it's not as simple as like a Venn diagram of overlapping circles. I have that slide, but it's really a matrix. It's three-dimensional, and I want you to think outside the box and realize your role in improving the public health in Missouri. And then I also, this color block, I've got action step slides intermittently throughout the presentation. I think I have about a dozen. So just have your phone or a piece of paper handy, because I've got a couple of websites or a couple action items that you can do after today. Any questions? All right, let's start with the health of Missouri. Some of the photographs of me and my patients I've been given explicit permission to share. I got very attached to my patients. Some of them I've been taking care of for 21 years. It is the greatest honor. You know, as a physician, you have individual patients, and then you have a panel of patients. And then you try to improve the panel of patients. And for years, I worked in population health, not just for my panel of patients, but my clinic's panel of patients, the St. Louis Safety Network's panel of patients, Missouri Medicaid's panel of patients. But about a month into taking this job, I was like, what's the population of Missouri? 6.2 million. In Missouri, we are currently ranked 42nd in our health outcomes. For all these national health rankings, the larger the number, the worse we are doing. So 44th in maternal mortality, 27th in infant mortality, and in fact, in Missouri, during the previously recorded year, we had an increase of 16% of infant mortality in Missouri. Cancer mortality rate, 39th. lower respiratory disease, 41st, diabetes, 16th, heart disease, 39th, kidney disease, 48th. I grew up in New York, and my father is like, Heidi, Missouri just keeps making the news. Just come home. And I'm like, no, I really love Missouri. I've been here for 21 years. They're really complicated issues, and there are diverse views, and there's so much that we can do that is innovative and exciting and can be incremental. Over 100 years, there have been tremendous public health achievements. From 1900 to 2000, USA gained 30 years in life expectancy. And 25 of those 30 years are attributed to public health efforts, including the following 10 great public health achievements: an investment in healthier moms and babies, infectious disease control, motor vehicle safety like seatbelts, family planning, tobacco use as a health hazard, declines in death from heart disease and stroke, fluoridation of drinking water, immunizations, safer and healthier foods. By the way, I made a mistake. Our senior staff had a get-together in a restaurant for like a team building, and I couldn't find my group, and they said, yes, can I help you? And I said, yes, I'm with the health department. And they're like, put the hairnets on. And workplace safety. But here's our most recent life expectancy. From 2011 to 2021, you can see Missouri's life expectancy has dropped 3 years. In the US, our life expectancy has dropped 2.3 years, and we are doing worse than the national numbers. So we have our work cut out for us. I've been driving around Missouri, putting many, many miles on my Subaru. You can see Kansas City up here. I've been living out of gas stations. This is Sedalia on the bottom. I have been so enriched and inspired by very talented people doing incredible things in our rural communities. I was impressed to see this Narcan vending machine down in southeast Missouri, but this is the Butler County Health Department, and it was the FQHC, Missouri Highlands, that made this available where people can get free Narcan. In the same town, I saw a vending machine for hunting knives. This state is fascinating.
Are those free too?
Yeah, no, those are under lock and key. And while living at a gas station, so I walked into one gas station in Warrenton, and I noticed that there were photographs around the women's room with dates, and they look like memorial. Now when I walked into this gas station, the people at the front desk were like, hello there, really nice, really connecting. I came out of the restroom and I went back to the front register and I said, do you mind about it? I was thinking, like, are they opioid overdoses? Are they COVID deaths? Like, what is the meaning of them? And she said, she smiled and she said, those were our regulars. The sense of community was very touching to me. People of diverse backgrounds, diverse political persuasions. There are so many sick Missourians that need our help. And I realized that my panel and our panel actually exceeds the number of patients that are assigned to us as providers. Okay, so action step number 1. Everything you do for patients benefits them, their families, their communities, and Missouri Health. Everything. The list is hundreds of items long. Every time you do an immunization, and I know that during the hospitalization, you got to do what you need to do and get the patient out and just assume, like, no, that's an outpatient issue. If you can throw in the immunization, please do so. Sometimes patients only pay attention to their health when they are hospitalized or when they are with you. The smoking cessation example, HIV prevention, being attuned to some of the radioactive exposures that we've had in the state of Missouri, especially on our east side, related to the Manhattan Project. Being sensitive to that. We're in a data-free zone. We don't understand what it's like for someone to live near low levels of radiation through residential exposure on a daily basis. But this is the art of medicine, right? The U.S. so the United States Preventative Health Services Task Force, gives us guidelines on cancer screenings, but we are not robots. We need to think about individuals and their individual risk factors given their history. In addition, we need to be as holistic as possible and not hyper-focused on the transaction at hand. Much of our healthcare system is based on transactions for acute issues or transactions for one organ system. I beg you to look beyond that, as many of you likely already do, and that makes you part of the public health continuum. Any questions before we move on to public health infrastructure? Okay. So, little civics course, but it's basically like, who's doing what? So, the governor has 17 departments that report to him. Each of those departments has a department head who is a cabinet member to the governor. The governor chooses those department heads. Every one of them is a political appointment and is subject to Senate confirmation hearings. Our director for the Department of Health and Senior Services is Director Paula Nicholson. I'm really proud to work for her. She's very insightful, very bright, and I report to her, I help her in running the health department. I want to point out a couple of these other departments just so that you see, one, how siloed we are, and many governments are, and two, how hard Director Nicholson and I and our colleagues are trying to interact with our other agencies. So in Missouri, the Department of Social Services is what houses Medicaid. You cannot improve public health across the state without moving the needle on health outcomes for your Medicaid patients. In some states, Medicaid is run under the health department. In other states, they are two completely separate departments. Historically, there has been some siloing, but under Director Nicholson's leadership, we worked really hard to work with them. We have a very productive partnership with them. We're partnering on GME, and I'll give you an example. Right now, Medicaid in Missouri is working really hard on maternal health outcomes. But for years, they couldn't tie the mom to the baby. They had separate Medicaid numbers. But in the Department of Health, we hold the responsibility for birth certificates and death certificates. So that's our Bureau of Vital Records. So Medicaid needed our vital record data in order to tie mom to baby. And then we could actually track the outcomes of what's happening to the baby as a function of how many clinical touch points the mom had with prenatal care. We've now shared that data. Sorry for the wrestling. We have now shared that data, and now we can make improvements together. The Department of Mental Health is separate, but just like as a primary care doctor, I will not practice primary care without integrated behavioral health. I will not do it without a social worker in our office immediately available. Everything we do in public health is also a function of behavioral health. We're trying to incorporate that in our work and partner with the Department of Mental Health. The Department of Public Safety is who we partner with for emergency preparedness. And do you know why commerce and insurance is up there? Partially for insurance, yep. And then the other one is that the Board of Healing Arts and the Board of Nursing and the Board of Pharmacy is housed within there. So the Department of Commerce and Insurance, they regulate physicians and clinicians. We, as the Department of Health, regulate facilities, hospitals, nursing homes, among many other responsibilities that I'll touch on. So those are some of our interactions, but I also want to point out some additional interactions. Department of Corrections. If we truly want to reduce the number of opioid deaths, overdose deaths in the state of Missouri, we need to assure that people who are in jails, state prisons, and federal prisons have access to substance use disorder treatment. And I also learned from one of your medical students that OB-GYN patients aren't getting care for their gynecological cancers. we want to work with the Department of Corrections. But the state Department of Corrections only does state prisons. Federal prisons are under another authority. And then I've only recently learned that jails are only under the purview of the county leadership. And I looked up Missouri statute. It's the sheriff of the county who determines whether or not someone in the county jail warrants medical attention. And I think we have an opportunity there to do better. And as Dr. Goodson was mentioning to me earlier, what happens in a county jail is exactly what's happening in the community. It doesn't exist in a void. What we put into our county jail comes out of our county jail. And it behooves all of us, from a public health and a population health perspective, to care for that population. For economic development, we are trying to tie our efforts with economic thriving. We've worked extremely hard to build graduate medical education, and we've gone from $0 to $10 million from our department in investment in graduate medical education. But we need to make an economic argument, and I've really enjoyed working with them. Elementary and secondary education is key because children's health is a function of, is tied to public health. And then higher education and workforce development, we have a healthcare worker shortage. Nurses, CNAs, physicians, we need to work with that department. And then the last one here is our Department of Natural Resources. I was sharing with Dr. Wooldridge that we had a very busy week. There was a legislative hearing this week about exposure to radioactive nuclear waste in the St. Louis region. And I've learned, like, what role does the Department of Natural Resources have? And their job is to assess and oversee the cleanup of the environment. And it's our job to work with them to understand the health impacts of those radioactive waste exposures. So welcome to how the Missouri government works. Most other state governments work in a similar way. Okay, so action step number 2. When you vote for governor, you are basically voting for a philosophy and vision for leadership of all 17 of those departments, including the Department of Health. An extreme example of this is that the Surgeon General in Florida, which that's what they call their chief medical officer, was a political appointee from their governor, and they are moving forward with a public health agenda that is consistent with the governor's priorities. Also, voting for legislators dictates our very precious and limited and important budget for health and other endeavors. Okay, how many public health departments are there in Missouri? So I work for the State Health Department. If we were in Arkansas, the correct answer to this question would be 1. Arkansas has 1 public health department that is centralized. I'm learning to honor and appreciate the culture of Missouri, of local control. Missouri has 115 independent local public health agencies. And it's our job to interact with them, to empower them. Remember this number, because I'm going to return, one of my last slides is like next steps. And part of our next step is how do we protect and promote our local public health agencies? Because every single one of them is tasked with every single public health effort. Tuberculosis, maternal child health, other communicable disease. Here are some of the local public health agencies that I've had the honor of visiting, including your own in Kansas City, Dunklin County, Butler County. Action step number 3. Get to know your local public health agency. Now, there's several adjacent to your medical institution, but they need help. They are understaffed, they are underfunded. You can call them up and say, I'm an interested medical student, I'm an interested resident. Is there anything, I've got 8 hours a month that I can volunteer. How could I be of help to you? You will meet some of the most incredible people in Missouri. You can learn, you can volunteer, and you can ultimately serve as medical director. Ideally, every single one of these local public health agencies needs a medical director to sign their orders, their standing orders. Sometimes a medical director, most of them work volunteer. Some of the larger public health agencies have like a part-time CMO that they're able to hire. But there's great opportunity for you to get involved now or 15 years from now and wherever you may be living. Our state also interacts with our federal delegates because I've learned that there's certain problems that we can solve as a state, and I want to run and pull that lever. There are some things that are up to the feds. So we need GME funding fixed on a federal level. We can do state initiatives in the meantime. Primary care is in crisis, and our current investment in primary care is probably 3 to 10%, depending on your definition of primary care. We are talking to our federal delegation to educate them about the need to define what primary care is, measure it, and then for us to reevaluate why the investment is so low. We need higher reimbursement for primary care. Primary care is an evidence-based way to improve health, and yet our country spends far more on specialists and we have worse outcomes. So we have so much room for approval. We have also spoken to our federal delegation about legislation to try to expand Conrad 30 to be 45 or whatever the number is, because we are treating wonderful, skilled international medical graduates, and then we are bleeding them from our state when right now Missouri is short 1,000 physicians. So we're working on that on a federal level as well. We can interact with individual legislators, and specifically when we go there, we speak with our Missouri legislators, our Congress folks and our senators and their staff. And then we also interact with HHS, the Office of the Assistant Secretary of Health, because they're part of our national public health system. Okay, so what do? I'm gonna go through this quickly. We have 6 divisions, and we have our Division of Administration where our grants and monetary and leadership goes through. Our Division of Community and Public Health is everything that you think about as classic public health. Cancer, chronic disease, communicable disease, environmental screening, lead poisoning, vital records. The Division of Cannabis Regulation is the newest division. When the amendment passed to make adult cannabis legal, the amendment assigned to our department the responsibility to regulate the industry. And I guess it fits because we regulate hospitals, we regulate and monitor and certify nursing homes, but this has been a steep learning curve. And initially, we were tasked with this without any funding to do public health education about cannabis. Fortunately, this past year, we had a NDI, which is a new decision item in the budget, to allow us to have a couple $1 million to start doing public health messaging about cannabis safety. And yet it's a very delicate line to walk between educating the public, but regulating the industry, and not being perceived as being biased against cannabis in our public health messaging to the cannabis industry. This has been a really interesting learning experience. The Division of Regulation and Licensure regulates hospitals. I've been called into a couple of these evaluations. If a hospital gets cited for an EMTALA violation or other violations, CMS contracts with the states to cite the hospital. And some of those cases are quite complicated, especially those recently involving women's health. And so I've been pulled into a couple of those cases. And then we have the Division of Senior and Disability Services. We have the Missouri State Public Health Lab, which, like, I toured that my first week. We have a wonderful public health lab, really smart scientists working hard. And then I operate out of our director's office where we're doing medical consultation, legal guidance, economic guidance. We're trying to improve informatics. We're working on policy and legislation, interacting with the legislature, and then disseminating public information. So here is the Department of Health in the state of Missouri. And action step number 4, we need you. When you see a policy that doesn't make sense, or if you want to contribute your knowledge in some way, please volunteer. Most clinical questions will come to me. And like a good primary care doctor, I know what I know, and I love a diversity of topics, but I know what I don't know, and I need help. I need a network of experts across the state. That is our website. If an issue comes up, go ahead and Google us and see if there's an issue. Reach out to that leader or reach out to me. One thing that I've learned working for the state government the last 2 years is that anybody can request a meeting. And you can as well. And very often those meeting requests are honored. We had a number of midwives that were promoting birthing centers, freestanding birthing centers. They wrote to the governor, they wrote to the governor's wife, they wrote to us, and they were able to meet with all parties to discuss the status of freestanding birthing centers. Just ask. Here's the other thing. When I was on the outside, I didn't realize that the government would be receptive to public comment. We are accountable to respond to public comment. Those comments are disseminated to the appropriate person, to the appropriate department. The state actually has a software to account for all of that. It was extremely important to Governor Parson that every constituent that had a question or had a suggestion that it be considered and responded to. So we have a lot of vital partnerships that are ultimately part of our public health. I'm going to fly through these so that we have time to chat. We interact heavily with the provider associations, so the OB-GYNs and the internists and the doctors, the family medicine docs, our rural health providers, hospitals, primary care outpatient folks, FQHCs and the Missouri Primary Care Association, other state agencies, 115 local public health agencies, educational institutions. And not only am I, as an internist, just so honored to be here, but my director is delighted that there's a connection between your prestigious institution and what we're trying to do in public health. Grantees, pharmacies and pharmacists. I have the responsibility of issuing standing orders for the state of Missouri. We issued a standing order for naloxone, and 11,000 prescriptions for Medicaid alone per year are filled at pharmacies with a standing order. This is something I didn't really understand before I had this job. So just so you know, anyone who's on narcotics or is at risk for overdose should have a Narcan prescription. I try to remember to prescribe that for each of my patients. But just so you know, every pharmacy in Missouri can fill Narcan or naloxone based on the standing order that our department has issued. So even if you don't have time to send in the order, just say, pick up a Narcan, just ask them to, like, there's a standing order in that. Anybody can get that. Insurance providers. This is a big lesson, right? You can't change public health without Medicaid, and you can't change public health and Medicaid without partnering with our managed care organizations, which our state gives a tremendous amount of money to in order to implement and improve healthcare. We interact with our federal partners, our federal delegates, and then I'm constantly looking for more intersections. Part of the reason why Director Nicholson created my position was to form these partnerships, because I can't imagine operating public health without it. So, uniting public health with healthcare delivery is the theme for today. And here's my meager attempt at a Venn diagram of, okay, where do we go? Well, healthcare delivery is over here. Government public health is over here. Maybe population health is in the middle. But really, like, the healthcare delivery is doing public health, and public health is doing clinical delivery. And I don't know, let's smush them all together. But even that's not good enough, because there's a broader public health ecosystem which includes all of these components as well. You can't improve public health if the economy is bad, if we have inadequate education. So I would encourage you to envision public health as a very big ecosystem, and you are a part of it. And I am grateful for your contributions and awareness of that. Action step number 5, write down this email, please. Our system of engaging physicians in public health alerts has been overdue. We are revamping our website. It should be super easy in the future, where you just go to our website and you can immediately just sign up for our alerts. But like when there's a congenital syphilis outbreak and we send out a health alert blast, it's going to the hospitals, it's going to some health centers, but I don't think physician providers have been invited to be part of this. If dengue fever is really high, if Missouri gets swampy and humid enough that dengue fever hits us, and we issue a health alert, you probably want to be the first to know. And so at this point, email this, say, I'm Dr. So-and-so, please add me to your list for all health alerts and advisories. Public health funding. So we have almost 2,000 team members and we have almost a $3 billion budget. But let's follow the money and understand exactly what that is. 78% of the state health department's funding actually comes straight from the feds. CDC grants, HRSA grants that come through us. And then we have to collect legislative authority. We can't spend the money unless Missouri legislators let us in the budget. So there's a formal process to grant permission for that. And then general revenue is really only 19% of our budget. And then there's other certain things that we can collect fees on, like if you're requesting an extra birth certificate, you pay a little fee, things like that. So let's focus on general revenue because Missourians believe in low taxes, which translates into low general revenue. So that's about 500 million, but really only 17% of that is used for DHSS, is my department, Department of Health and Senior Services. 17% of that is used for like our core funding. Most of it goes to home and community-based services. So when somebody with high needs has a home health aide, that's quite expensive. That used to be run under Medicaid. And for some reason, historically, just that one part of Medicaid was carved out and plopped into our department. So even though our budget looks really big, most of it is money coming through Medicaid to pay for home and community-based services. So you take that 17%. This is a demonstration of how much states across the country pay per person per year on public health. We are 51st in the country for our investment in public health. So although health and public health should not be political, some issues are, but regardless of those issues, just protecting our $7 per person per year is really important, and it's part of our job, and it's part of my job to convey to our legislators that work on our budget every single year of why funding for each of these programs is important. If you're interested in learning more about this process, show up for a budget hearing meeting. All the hearings are public. Please.
What are the interventions that places like Arkansas and DC do with this extra money? Are they known for in the public health community?
So I don't have an answer to that. It's a good question. But what I have learned is that public health is so many things. So there may be a philosophical support and approach for many more of those things. And I'll show you a demonstration of like all the different areas of public health. And I don't think it's just one that gets more funded. I think it's a general understanding that public health is something that our society needs. Any other questions or comments? In the US, for every $1 spent on healthcare, most countries spend $2 on public health and social services, and the US spends 55 cents. Next item, let's get right to health policy. Okay, so our intersection with the legislature, with the House and the Senate has been fascinating. It is just as important each year what bills pass and what bills do not pass. Last year, a staggering record it was about 3,400 bills were filed over the January to May standard legislative session, and we had the lowest number of bills passed. So 48 bills were passed, but a portion of those are the required budget bills. Like we are legally required to pass a budget, and passing the budget means you pass different bills. So if you take out the budget bills, only 28 bills were passed last legislative session out of 3,000 filed. I will add that some of those bills that passed were great, and I'll highlight some of them. When I say great, I mean beneficial to the health of Missourians. In the 3,000 bills that did not pass, there were some really wonderful opportunities that didn't pass, but one could argue that there were some potentially harmful things that didn't pass. Action step number 6. The Missouri legislative session is January to May. Memorize that. Have fun with it. Learn about it. Use a legislative tracker. There's great software that's free and super interesting, and whatever individual issue that you're interested in, whether it's women's health or kidney disease or the medical student pipeline, you can put in search words and then you can get alerts and you can dictate how often you want to get alerts. I recommend weekly if you're not like immensely detailed and entrenched in it, because I know you all are so busy. There are many trackers. One example is fastdemocracy.com. It's a helpful tool. And then I learned it's St. Louis based. So it's support Missouri businesses. All right, so how do we change Missouri policy? Number 1, you can change a state law. But remember that slide I just showed you? 28 bills passed last year. So it's hard, and 3,000 didn't. So it's a powerful way, and I've witnessed this. The GME growth that we've had was a function of a bill that passed last year. You can change state law. The other very powerful way that you change health policy in the state of Missouri and in most jurisdictions is that you change the budget. And I've been learning my political science as I go along. Sometimes if you put something in the budget, it can happen. Sometimes you need accompanying legislation, sometimes you don't. And sometimes these are 2 separate processes. The third thing was a helpful lesson that I wish I understood as a medical student, resident, and physician. Health policy at the state level occurs at 2 different tiers. So a law is passed, but the law is short. And the law gets assigned to one of those 17 departments that I demonstrated. So if they say, we want this, and the Department of Health is going to take care of it, then the Department of Health has to write regulations. Regulations are also called rules. And the process of writing regulations can have a very big impact on how that law is implemented, and you get a say in it, and our department gets a say in it. And I have a couple slides to focus on the opportunity for you to have input on the regulations. This dichotomy, but not a dichotomy, but the tiering, like a law and then the regulation writing, it's really important to keep in mind and to look through that lens. Because sometimes when you want to change state policy, the question is, well, can we just do this the way the law is written and just adjust and revise, update the regulations? Or does this require statutory change, which means passing a law? It's much, much harder to pass a law. It's much, much easier to reevaluate and revise regulations. The fourth thing is to optimize state program implementation. So many of you, and I watched the lecture last year from Bridget McCandless, and she had mentioned that the state has many boards and commissions that you can serve on. Like, for example, the Department of Health has an oversight board to which we need to report. That's one way in which you can have input. You can also just come talk to us. Say, like, I know you have a new law about this with this cannabis thing, but you need to know that there's new data on the use of cannabis by pregnant women who are taking it for morning sickness, but they're having adverse health outcomes. Let us help you with that. I would tell you that our health department is eager and thirsty for reliable, evidence-based clinical medicine information. And then number 5 is to provide data, build coalitions, and contribute to impact non-government organizations. Your organization, or a nonprofit organization, or the American Cancer Society, or whatever the case may be. There's so many opportunities to influence policy. And then, of course, there's voting. Even better, run for office. I'm just going to plant that seed, because maybe one of you will one day. Questions about this? Please.
So the previous slide with the money per person on public health, does that directly correlate with the health outcomes in that state?
We are 44th in the nation for our health outcomes. So the exact correlation, I haven't done the analysis, but there is data to show that lower investment in public health leads to poor population and public health outcomes. Great question. Please.
So I know when they passed cannabis, they were gonna tax it at higher rates to implement some of this stuff. So where's all that cannabis taxation money going if it's not to public health?
3 places. To the department just to run the program. It is a lot of work to run the program, to make sure that if a vendor says they're selling cannabis, that it's not contaminated, there isn't mold in it, that it's actually the percentage of cannabis or THC that they say it is. So money to run the program. That comes off, that's one component. And then also it goes to the Veterans Commission, which is a government agency in Missouri. And then it also enables us to give grants for substance use disorder treatment. And then some of the funding goes to the public defender's office to try to eradicate some of the crimes that have been documented and people have been imprisoned and penalized for cannabis-related crimes. But none of it goes to education or research on the impact of cannabis on public health.
It was in the paper today, right? There's not that, it didn't look like the dollar was that big. It was like $4 million or something. Was the headline in the paper today at least?
Yeah, we released a press release a little while ago. That may be quarterly or annual, I don't know off the top of my head. Other questions?
So with that specific issue you mentioned, I was going to ask about research for that specifically. Is it even legal for a state to invest in cannabis research if it's illegal at the federal level?
So I need our general counsel to answer that question. But I will tell you that part of the amendment that made adult cannabis use legal in Missouri had a component to it that we were tasked with developing regulations. Remember the difference between creating a law and writing regulations? We had to write regulations related to cannabis education and research. That was the last component to be implemented. And currently, and I did reach out to your institution, I really wanted to make sure that as the state had listening sessions about how should we do cannabis research in the state of Missouri, that our esteemed professional, expert, academic researchers would participate in providing that input. And we had 2 in-person meetings, a virtual meeting. If any of you in the room are interested in contributing to informing how cannabis research should be regulated in the state of Missouri, I want your input. It's probably not too late. You can email me directly and I will forward it to our Division of Cannabis Regulation. I personally recruited academics across the entire state, and we had similar representation at the meeting as industry. And if we don't show up for that, then we have our cannabis industry asking for regulations for cannabis research that entails agricultural research and how to research how to grow like the finest optimized strain. But we have a paucity of data on the health impacts of this, especially for a geriatric population. There are many older patients that are using cannabis, and it's just completely unstudied. Any other questions?
Was it Arkansas earlier you said was the state that had a single health?
They have a centralized public health system. So they have a single public health system, regionalization, but like they're able to distribute information and coordinate services from the center, from their state health department. Whereas we in Missouri have a decentralized public health system where we have the state agency and all the local public health agencies are operating independently, but we have relationships with them and they get some funding from us.
So I was wondering if the differences in the funding was related to the number 1 versus number 115, that if you're funding 115 local or regional offices as opposed to one major, whether,
Isn't that
seems like a big difference.
So AK is Alaska, not Arkansas.
Oh, yeah, you're right.
From Europe, so
Yeah.
where is Arkansas?
But I've had to review my geography a few times this year, including all of our adjacent
Where is
states.
Arkansas?
Arkansas is the 2/3 from the.
Oh, AR, I see it, yeah. Oh, okay, good.
Even still, they're higher, and your point is valid.
goes to $50.
No.
Thank you for that.
I'm going to move forward real quickly because I know we're running out of time, but I know we have to end at 1 o'clock, but I was much more interested in taking your questions. At the 1 o'clock part, I'm happy to stay after to answer additional questions. But at 1 o'clock, if you need to go or before then, no feelings hurt, just get up and don't hesitate. Okay, so we talked about policy, and you can contribute to policies by talking to legislators, and you can comment on proposed regulations. And I'm just going to let you know briefly, if you go to the Department of Health website, at the very bottom, there's a tiny little phrase that says proposed rules. And if you click on it, you can see every rule that comes up has 30 days for people to comment on it. And now that I've been on the inside, I realize that every law that passes will have regulations that follow. They are required to do public comment, and we are required to read every public comment and respond thoughtfully. Either take the recommendation or respond with a reason why we can't take that recommendation. So this is your opportunity to contribute to policy. Here's another example of that. Okay, so I'm going to spin through this real quickly because of the interest of time, but there are so many interesting things that are happening in the state right now. With graduate medical education, Missouri has never invested in this from the Department of Health side. Medicaid started paying for it a little bit 2 years ago. The Department of Mental Health has paid for some graduate medical education for some of the psych hospitals and the state hospitals. But right now, Missouri is short 1,000 physicians, including 600 primary care doctors, 160 psychiatrists. Last year, we got $2.3 million for GME. And once we started that, we learned all about GME and realized that, like, instead of just expanding slots in existing programs, we need to have new programs in nascent facilities. We need current competitive programs like your own to develop rural track programs. We want to pay you to do that. There will be feasibility studies. We're going to develop a technical assistance center. As of now, over our efforts over the past 2 years, we have $10 million of both state revenue and some of our opioid settlement funding invested in GME because our department believes that substance use disorder should be integrated in everything that we do in multiple specialties. Medical student pipeline, we're working really hard on it. We have learned that not only so Missouri, we're great at generating medical students, but we generate about 1,000 medical students per year, but we only have 700 GME slots. So that's why we're going more GME slots. But even before we get to graduation, we are losing hundreds of medical students, mostly from our osteopathic schools, from KCU and ATSU, that when they finish second year and before they start their third year clerkships, they move out of Missouri to Colorado, Florida, New Jersey, Arizona, many other states to finish their clinical clerkships because we don't currently have enough clinical clerkships for our own Missouri medical students. That I quantified that as we're losing 300 Missouri medical students after their second year, which is has such dire consequences for the state. The preceptor tax credit for those of you who are trying to recruit community preceptors. I know some of your pediatricians are trying to get, the med-peds are trying to get some pediatrician preceptors. There is now a tax credit of upwards $1,000 to $3,000 that a preceptor can get if they can document that they've spent hours mentoring a medical student and are not paid otherwise. So if you're already faculty on UMKC, you wouldn't be eligible for this, but this is how you can recruit some of your community faculty. We worked on maternal health, and I developed with our director an interagency group. We also have a new maternal health access project. So if you're interested, please stay later. We now have a phone line and a contact so that if you are taking care of a woman who happens to be pregnant, who's having a behavioral health or substance use disorder, or she's a year postpartum, you can get free advice from a perinatal psychiatrist the same day or the very next day to help them. So you don't have to wait and say, like, well, I don't feel comfortable prescribing these meds, and it's going to take 3 months to refer them. This is an incredible program. The governor just passed this in their budget last year. You just have to sign up for it, and I have a slide for that, which I'll turn to at the end if you're interested. Cannabis public health, education, and regulation, I already mentioned. Opioids in jails and standing orders for opioids. I also mentioned we're interested in reducing opioid deaths, and I think we need to look and see what's happening in our jail population. One of the bills that passed last year was actually an insurance bill that had one clause in it for the Missouri Show Me Healthy Women program, which is free breast and cervical cancer screening for women who can't afford it. If you get diagnosed with cervical cancer or breast cancer through this screening program, Show Me Healthy Women, you get a ticket to Medicaid. But the problem is, if a woman didn't know about this program and she went to a facility that's not registered with Show Me Healthy Women and she can't afford health insurance and she gets diagnosed with breast cancer, previously she couldn't get Medicaid because you didn't start with the Show Me Healthy Women program. So obviously that's not the intention of this program, and a law was just passed to show there's no wrong door. Even if a woman didn't start with the Show Me Healthy Women program, if she has breast or cervical cancer, she can get a ticket to Medicaid. That's great, but we also have to remember that women have colons and lungs and other parts of their body. And in the state of Missouri, just because you have colon cancer, it doesn't give you a ticket to Medicaid. So we have a ways to go. And then team-based care, I know our Medicaid division's working very hard to independently pay doulas, community health workers, and emergency medical technicians and paramedics that are doing mobile integrated health. I'm gonna stop there because my time is up, but I'm gonna fly through to, see, I got so excited to tell you so many things today. I'll just come back for another few hours. I'd like to end with this slide where you can email me. In terms of next steps, we're looking at all those policy issues that we've mentioned, and we're also looking at something called foundational public health services. Most of our 115 local public health agencies are struggling to fulfill the very, very basic public health services. We're sizing that, we're measuring that, and soon we will go to the legislature with a very big ask to say, these are foundational health services. This is what our 115 local public health departments say that they can do. We need help, either strategic realignment or more funding for services. I'll stop there, and I'm happy to take additional questions after that. I'm sorry that I went over. No worries if you need to go. Any questions or reflections or suggestions?
The question I have is, we have 115 local public health agencies. What kind of coordination is there? Are we really taking unique approaches, or is there a commonality?
It is very challenging to interact with 115 of anything. We do have part of our department dedicated to having relationships with those 115 agencies. And we have special, stronger relationships with the smaller agencies. We have some really strong, powerful, wonderful, smart public health agencies in Missouri. So in Kansas City, really strong. St. Louis, Springfield, Boone County. But there are some of those local public health agencies where they literally have one person. Or maybe they have someone who's doing WIC half the time. But like if there were a COVID outbreak or a dengue outbreak or a tuberculosis outbreak, we're talking about half a person. There's not enough funding, the staff is underpaid. And so the smaller health departments depend on us more, and we have strong relationships with them. But there's only so much we can do with their resources and our resources. Other questions or suggestions?
How did you get your job?
I was looking for a new challenge and really cared about the state, and went on the Missouri State website and applied cold.
You still do clinical work?
Yeah, so this is a full-time job, and I got permission to continue clinical work, which I have to do in my free time. And so fortunately, because I've been at my clinic for 20 years, they'll let me work a little bit. I guess for question and answer, we can turn this off.
It is, I work on Friday afternoons in my clinic,
And in some ways, it's like coming home. In other ways, like everything I learned about during the week, I have like all these like frontline workers who know exactly what's happening. Like I've spent a lot of time on the nursing workforce. It's really such an honor and a privilege to just walk into the nurses' room and just pepper them with lots of questions. But I will say that clinical care is so intense that I love it. It's part of who I am. I want to keep the skill set. Part of my job is political, and I could lose it for political reasons. I don't want to lose my skill set. But I can be the chief medical officer for the whole week, and it's still not as hard as trying to do 12 patients in 3.5 hours on a Friday afternoon in a current system. I still love it, and there's an adrenaline rush, but it keeps me highly, highly motivated for us to improve primary care as a way of improving public health. Any other questions or suggestions? What does Missouri need to do that we're not doing?
It was really interesting learning about the different cabinets. I should know more about that, I just don't.
Speak up a little bit.
Oh, sorry, it was very interesting to learn about all the different cabinets and how all those intersections occur.
For me too.
So as I think about a problem like the number of rural hospitals closing in our state,
Yeah.
it involves, I would guess, just based on your description, 6 or 7 plus different cabinets
Yes.
to address that.
Yes.
So how do you begin the process of collaboration in those groups with the lens of the political environment as well from the state government perspective?
So I'll tell you how we do it. We work closely with the Missouri Hospital Association and we learn from them. They convened the leadership in the Department of Health, the leadership of Medicaid, and the CEOs of the rural hospitals that are birthing and are at greatest risk for losing their birthing capacity. And we sat with them for 3 hours and we listened. And they were all like, they're all so morbid. They're like, we're 1 car crash away from like losing our OB services, meaning like it's the OB-GYN who's gonna be. And then we took that and our director started this maternal interagency group, which is, there are maternal health forums across the state, but what we tried to do is a very policy payment-centered group. So we selected the very top leadership of Medicaid, our department, the Department of Mental Health, the Missouri the Missouri Hospital Association, the Missouri Primary Care Association, EMS, and the leaders of the Medicaid managed care organizations. And we started an in-person meeting and we emphasized that it had to be, like, you need executive buy-in. And most of us aren't specialists in maternal health, but we reviewed 60 programs and policies to improve maternal health specifically for the rural hospitals. And we narrowed it down to a list of a dozen. And now each of our agencies are working together on that dozen. We're meeting, we're doing like, I love bringing agencies together. Like, it's just like middle school, peer pressure catalyzes action. We're doing this, oh, I didn't realize you were doing that, oh, we need this, and then you get the opioid settlement funding that gets dumped in our lap beautifully, and we're like, oh, let's use that. And so we're working on those initiatives now to protect rural hospitals and to protect maternal health. But rural health, there are statewide optimization levers that we can pull, but there has to be a federal solution. It's just stupid. Rural hospitals are closing all around the country. Now, honestly, maybe some of those hospitals closing was not the worst thing. You know, having a bit of duplication as the town's population has gone down, supporting 2 hospitals in a small town, maybe if one is underperforming, it's not the worst thing in the world, but that's just like the first couple. But now we're just creating healthcare deserts. And so how do we stop that? But if you figure it out, Sarah, will you let me know? Because it's really hard.
A quick comment and actually a question for Sarah. So I'm a product of this school and our residency, and I'm not saying we didn't have any education about the intersection of public health and policy and delivery. I'm just saying if we did, I forgot about it like I did so many other things.
I don't think,
I know that it's not in our curriculum in residency. 5 years ago, we have an annual Quality Patient Safety Day, and Betty Drees, our former dean, recommended that our keynote speaker should be a guy, Sam Page, who was a couple years ahead of Jared and I in school. And I thought that-
UMKC?
Yeah, he went to
Sorry, I didn't realize
UMKC, so he and Jennifer were a couple years ahead of us. I thought that was a ridiculous choice for Quality Patient Safety Day. Man, if Sam didn't make me a believer, I'm like, well, what does government have to do with QI, with the stuff I'm doing in the clinic, and I'm like, I did not have even like the vision for that. I was just so naive. And then Bridget last year, and then you have sort of helped illuminate that for me a little bit. My question then for Sarah is, do we have anything, I'm saying like, I'm guilty at not doing any education around this. Is there anything in the curriculum? Is there anything that the LCME says that we need to be doing in that regard?
There's not in the LCDs. What we're trying to look at is very early in the medical school, how do we get exposure to all the different facets of what a physician does in their community and what they do for community. And advocacy is becoming an increasing role in that. Actually, my exposure through pediatrics, because the American Board of Pediatrics for board eligibility has required components of advocacy in that. And so that really got me to thinking about, why does this need to be kind of one more thing in the loop of the enormous list of things that medical students have to learn about. And so yeah, we're trying to do that, but the question is, when can you do it? Does the students actually have the time and the space to stop and think and consider that as an option for their future career?
I think the key is integration. I think setting aside an hour a week for 3 months to teach this is not the way to teach it. I think it is integration, and that really then comes back to the higher level of faculty and engagement, and recognizing that, like Dr. Miller said last night at our dinner, every single clinical encounter is an advocacy opportunity for us. And it's hard because we have to teach them so much. We have to teach them about the knee exam and everything, but I really think integration is the key, because I don't think we're gonna find time in the curriculum at all. And I'm sorry, I probably interrupted you, but that came to mind is I don't think it'll be effectively taught that way either. I think the effective way to teach it is integration in our residency clinics and the hospital wards, and what's really determining those, and then what are the policy and regulation that's affecting that, and how do we change it?
So interestingly, one place you can integrate this is with longitudinal integrated workshops. So in our regional campus at St. Joseph, where the students go out to those regional sites to do these longer integrated workshops, this is one of our next phases, we fortunately have HRSA funding to help with this, is to get them into the health department their first week there, to get an understanding of what are the health concerns that people are worried about for that community that they're serving, and then have an opportunity to do a small project to start seeing themselves as that public health community physician, and not just the person who's trying to survive their 2 half days in the clinic.
Great.
I agree that would be the ideal, the integration, no doubt about it. And yet, Sam's talk 5 years ago, that hour was time well spent for me. Bridget's last year, if we were able to get more than 2 students together for you to chat with, would you come back and inspire them for a moment and just give one of those students, 2 of those students, the opportunity to kind of remember that and reflect on it, and then and who knows how that changes kind of their vision, their path.
I'm happy to help, and I mentioned to Sarah, I shared a talk with you yesterday, but I can give this talk to your students if they're interested. Over the years, mostly because I've been in the St. Louis area, I've dealt mostly with WashU and SLU students. They are so hungry for policy, but it's so enigmatic to them. It's just, the only thing they know to do is join the student part of their physician advocacy organization, when there's so many cooler things to do. That's important, but there's so many individual things to do, and one of the best things for a medical student to do is to be in a room where they're the only white coat, not literally but metaphorically. Put yourself in a room where you're the only medical person, and there's so many opportunities for that. They're hungry for it. It's not like, we're gonna give you one more thing to learn. Also, I'll give you credit for, like, you have an environmental health curriculum. That's public health, that's public policy as well. That's the first I've heard of.
I just wanted to mention that, you know, when Dr. Wooldridge talks about 2 med students hearing your talk, I think kind of we emanate that as residents now. And, you know, we're busy learning everything we can, but this is in particular, this kind of strikes me because I didn't realize who's me, that I have the power to talk to somebody and get some of the frustrations that we face in our community here, which is quite a lot with social determinants of health, that there is a chain of command, that we're not just stuck, that there are options there. And I think a lot of us in the throes of residency had no idea that there are opportunities to get involved other than joining your committee, right? Joining your local committee.
Yes.
And so I think this is particularly important to disseminate to the younger students and learners to be able to understand that we can go to this website and input on things that we're seeing every day on the front lines. So
And your voice is valued, and especially as a medical student, I'm sorry if I'm repeating myself, but prior to this job, I testified to a number of hearings on access to care and Medicaid. And one summer, I had a student working with me, and when I went to go I went to go testify at one of these hearings about health access and what I'm seeing in the clinic. I had my prepared remarks. He and I were driving to Jeff City together. It was a 2-hour drive, and I was like, you know, Brian, would you like to make some remarks? He goes, oh, no. You know, he's deferring to me as the doctor, like, oh, no, just you, Dr. Miller. I was like, no, I bet they would welcome the remarks. You're part of the future physician workforce. Please feel free. And at the very last minute, he's like, I'm gonna do it. I'm gonna testify. And so I went, and he went. So I did my prepared comments, so they asked me 1 or 2 questions. It was probably 8 to 9 minutes, and then I sat back down. And then Brian went up, and I said, this is my medical student. They kept Brian at the table for 25 minutes. They were like, where are you from? What are you interested in? Do you want to do primary care? Do you want to live in Missouri? Why not? What do your friends want to do? What do they teach you in school? They were fascinated by what he had to share. So everyone, it is such a privilege to get into medical school and to be part of this profession. And you are immediately trusted by our policymakers as having the capacity to inform how we're going to fill this public health crisis of being short 1,000 physicians in the state of Missouri. How are we going to fix that? Through young trainees. So one quick tip. I know that UMKC probably has a government relations person, and there's going to be a lot of bills coming out this year during legislative session, which is January through May. One of the bills that came up last night is that the bill to get rid of prior authorization, or to tamp it down with like a gold card access. It came so close to passing last year. It will probably be represented this year. And hearing from you about prior authorization would be key. Go ahead, email your government relations people and say, like, if any bills come up relative to care and you need like a clinical voice or a physician pipeline voice, will you please put me on your list? And especially if you're doing the legislative tracker and you know there's a committee hearing, you can contact them and say, can you get me on the witness list to testify? Just put yourself in front of them, and I'll tell you, the legislators are much more interested in hearing from you than the same lobbyists that they hear from all the time.
Yeah, I encourage you to go to ACP's. Dr. Lathan was there, I was there this year. Like, that was the first time I'd been there, and it seems intimidating to go to Advocacy Day in Jefferson City, but it is very easy to do, and people listen, and
It's fun.
it's fun. Yeah, actually it was kind of fun.
It's like the coolest field trip you'll ever have. But unlike being an elementary school student, they actually want to hear what you have to say.
So you have a day in February, when it's usually in February. We usually do it together, so.
Yeah.
So it's a good day. Everyone else is on Jefferson City, so doctors need to be there too.
But you can also come anytime, and you can coordinate that with your government relations person, or with ACP, or with the MSMA, or the Missouri Primary Care Association. It's a little easier to align with the organizations, but you can do it as a solo too. Thank you. I know we're running out of time.
Thanks, everybody, yeah.
Thank you for saying
with Dr. Miller out in the lobby before